This 25-year-old male returns 1 month after placement of a 20-millimeter lens for drainage of a hemorrhagic pseudocyst secondary to alcoholic pancreatitis. Drinking very heavily, although he claims to have stopped drinking almost a year ago, but he's had recurrent attacks of pancreatitis. Now you can see, just coming in, there's pus, so there's infection present. So we have to maneuver our way into the cyst and take a look at what's left here. So you can see it's infected, and there's necroses. So what we're going to do first is just see what we can tease out on necroses. So this is one of the reasons why I feel very strongly that these patients get nasal cystic irrigation after drainage, or in conjunction with drainage. This would not occur if there were irrigation, a way to irrigate the cyst. So you can see the challenge of necrosectomy here is just that these necroses are very adherent, sticky, and it's really hard to tease this out. I think it's attached to deeper necroses, so it's probably going to require active necrosectomy. I can try to give me a rat tooth forceps. Okay, open. Just kind of grab that necrosis, sort of pull it in here into the cap, apply suction as we're doing this. You do need to use the therapeutic scope when you're doing this. You can see we're starting to tease a little bit of this out, and then we'll deposit it immediately. 1 moment. Wait. Okay, deposit, please. Good. Close. We'll go back in again. Open. Close. Okay, pull it into the cap. So as you can see, what I'm doing here is I'm holding with suction the necroses closed, but also with the forceps to try to tease this out. Okay, it's looking promising. You can see we got a big chunk here. Just keep pulling on this. And the limitation might be just how much we can really tease out. Okay, again, grab it with, open the forceps, please. Close the forceps. So we're using the forceps just to try to hold a chunk in the cap, and then sort of twisting and turning like this with suction, trying to pull it out. Now, I often will use a deeper cap than this, but I don't think it's going to make that much difference. Okay, looks like we got a nice chunk here. Okay, the question is just if we lose it at the last moment. Can you hold the scope here, please? Trying to pull a little bit more. Okay, came off. Open. Close. Now the other technique is just to sort of break up the pieces here and just opening and closing. You have to be very careful because you don't know what's behind it. So just make sure it's kind of under vision initially. Open and close rapidly, please. Yeah, and then just sort of beating the necroses with the forceps and trying to break them up. You don't want to grab obviously the axials either. So now I'm just sort of going back and forth trying to break up little chunks. Looks like I can't see. It looks like we got some chunks that are, you can see there's also pus pockets in here. So this is something we really do need to evacuate today. Okay, open. Okay, open and close again. 1 second, we're at an oblique angle to the axial, so there's a risk that we'll grab the stent itself. We don't want that. We want to be in the axis of the saddle. Okay, open and close again. Okay, and then just sort of, again, rapidly beating. Okay, 1 second, please. See, the question is if we can get this small enough to be able to grab some pieces, open and close again. The fat necrosis that causes the obscuring of our view here, smearing of the lens. All right, let's just sort of see what we can tease out, because I think we're at the point where we can determine if it makes sense to continue. So let's take this out for a moment. So it's really not coming easy, is it? Yeah, so we need to go now to powered endoscopic debridement, PED, with the Endorotor device. Okay, so I'm going to come out and we will set up for that. I'm now introducing the 6mm channel gastroscope. So we call this the clotbuster scope since it's was designed for removing clots or food in the stomach, really. It has multiple purposes due to the large channel. But in our case, we're using it to introduce a catheter that's 5.1 millimeters in size. And it is a catheter that contains an inner rotating blade that enables powered endoscopic debridement. So here's our 20 millimeter lambs, and we're going to slowly turn into that here. And now we're going to introduce the 5.1 millimeter catheter through the working channel. It's a snug fit, so we've lubed up. This sheath actually is also hydrophilic, so that helps. And so this outer sheath stabilizes in inner catheter that has a rotating blade at the tip. So there's an outer catheter or sheath and an inner catheter with a rotating blade that rotates at very high speed. So it's has two speed levels, 1,000 or I think 1,750, so 1,750 rotations per minute. And the outer sheath has a window. So now I'm going to straighten the scope first because I have some resistance advancing it, so I want the scope to be straight so I can advance this out of the working channel. So pull it all the way back in the esophagus. There it is. So now you can see the tip. So you can see a solid black line. So the window is on the opposite side. That window, I don't know the exact dimensions of the window. The first generation was 4 millimeters. This is clearly larger. But here you can see the window and it's really about the circumference, right? So I think it's probably a good 5 millimeters in diameter, the window. Just don't know the exact length of the window. And then there's a rotating blade, which you can see. I'm going to try to hold this position like this and negotiate my way into the saddle portion of the lambs right here, and we're going to start here. Now the problem is that you really don't want to have much excessive torque angulation of the scope when you start. So we're going to start the rotation of the motor outside just to be sure that it works. That it's rotating, I should say. Because it may not, sometimes it won't work or start up when you're angulated at the tip. So it's relatively straight now. And we step on the blue button, which activates the motor and rotates the blade. So let's see if that works. You see the blade rotating now very nicely. And it's at the low speed right now. All right, and you can see I can rotate the window position. Now the motor will turn off on its own after 8 seconds unless I then press the orange pedal, which activates suction. All right, so I'm going to release the suction. I don't want to have that as I go in right now. I'll let this just sort of continue. I've got 8 seconds to get in. All right, and then I'm going to change my position. I don't want to be, so I'll turn it on again. It's on again. Yeah. So let me see, I just kind of fell back a little bit. So I got to pull this back just enough so it doesn't interfere. There we go. So this gets a little tricky in the beginning, but you can see now with the suction, I was just pulling in the necroses. And I'm just hovering right above and just letting it pull the necroses in. I have to keep my foot on the orange pedal to have continuous suction. And in this case, I'm not so nervous about using gas. If I place the fresh lambs, and there's a risk that there may not be good apposition of the cavity with the bowel wall, the stomach wall, then I want to be very careful with gas, and I'll use water. But in this case, I think we can just stay with gas for now. Now, when it gets kind of stuck like this, I'll very cautiously turn the window around a little bit to get into a better position. Here you can see it's sort of starting to pull in. And every once in a while we have to declog this if it gets clogged. And so we will flush out and declog if it looks like we have necroses that's clogging up. I'm going to rotate my window a little bit. There's the window. So we can just intermittently declog. And then it also helps to put some water because that'll help suction out some of the necroses. Just makes it a little bit more fluid. Just got to be careful. If you do this with water, of course, you have to have your patient intubated. Just sort of keep this under view now as we see it rotating. You can see we're getting very close to the. Now you actually get some you actually pull in just by the rotation, pulls in some tissue. It doesn't have to have suction. And now I've activated the suction. Can you take a few photos while I'm doing this? Yeah. Look at that. That's really great. I just didn't want to interrupt my view. So here, looks like it's still sucking in. Just gliding over the surface. Very slowly chipping away at this. It's good that we've got a whole month now since the Axios, the lambs, was placed, because that really makes sure now you can, I can extend under vision like this to a more distal part.